So we'll start this very important meeting on sustainability. I think we have my mentor and a great person behind sustainability, Dr. Chang, who is going to give a brief introduction about why sustainability is important and what is iSustain and what we can learn from what iSustain is doing.
All right, well, thank you, Vinky, and great, my presentation's coming up. And as soon as we can put it up here, perfect. So I'm just going to give a little bit of an overview. I have to leave for another course, and then I'll come back at the end. And I have no financial interest in global warming. So the first question is, why should we care? I push the limits of what we can reuse in the United States, of course, but it's still a huge ton of waste. And we just should all be aware that the WHO has told us that climate is the biggest health threat facing humanity. It's not an infectious disease. And as I think we know, this is going to disproportionately affect those societies, countries, populations least able to deal with the increase in morbidity and mortality. Our own IAPB has highlighted what can happen in eye morbidity and mortality related to the climate crisis. But here's the thing. We are a big cause of that. The healthcare sector, if it were a country, would rank number 5 in the world in terms of carbon emissions. So the healthcare sector is a big contributor to this. The United States is among the worst. Almost 10% of our CO2 emissions are from the healthcare system. And the majority of this is from the manufacture, use, and disposal of supplies. And within healthcare, what's one of the biggest generators of waste? Well, with our volumes now approaching 30 million cases a year, ophthalmology and intravitreal injections is huge. So this was our paper, 2 million consecutive eyes, which we used to show the efficacy of intracameral moxifloxacin, 1 million with and 1 million without. You can get the rate down to 1 per 10,000 with intracameral moxi. And what's notable is that the Aravind Eye Care system, as you'll hear, reuses all of these things. And all of these are in many institutions in the US, and certainly you can't use topical drugs on multiple patients. Everything else we have to throw out each time. Aravind is unique, as you're going to hear, because they actually standardize everything else. So if you take our study and you go back and take the data and just look at you can get the infection rate from what happens when you do 2 million cases and you use all of this stuff that it's illegal for me to use, reuse in the United States. And you get a rate of 4 per 10,000. Remember, half of these eyes had intracameral moxifloxacin. So what is it in the United States where we throw everything out, mandated, in order to make surgery safer? We should be doing much better, right? We're doing exactly the same. This from the IRIS registry data, overlapping period, 8.5 million consecutive cases. Similar. Some of these are getting intracameral antibiotics, some are not. So let's see, we are spending and wasting 20 times as much. Vinky is going to cover his study about the carbon footprint, and we're getting no value, no safety from that, which is infuriating when you think about what we are wasting. But the optimistic message here is we could cut what we're spending and wasting by a huge amount and not endanger our patients. It won't affect safety. So how controversial is this idea of reusing things? Cassie Teal and I wrote a survey, and we first did this in North America, more than 1,000 respondents. We later did this for the European market, and right after me, Wendy C. is going to give you the preliminary results of our APAO survey. We're using the same questionnaire in all of these. And what we're finding is that, surprisingly, most doctors are, 91% are concerned about global warming. Everyone feels that trash is excessive. We need more reusable, multi-use options. And gosh, manufacturers and regulators should at least let us as ophthalmologists determine what is okay to reuse. Now, we are using intraocular and topical drugs and supply items on multiple patients, and you can go down this list, and this is currently reusing. So intracameral antibiotics and things, 95% of us are willing to reuse. Supply items, including phaco tips and the tubing, and this is important, more than 3 out of 4 are willing to reuse the phaco tubing and irrigating solutions. This is the drapes, okay, whoops, sorry. And this is interesting, okay, so, 2/3 are willing to reuse the gown and not change it after every case. Makes sense, it's clean. This is something else they do at Aravind, and has been copied throughout India, is having multiple patients in the same room. It really improves efficiency, but of course, we're not allowed to do this because of cross-contamination. So this is our study that Dr. Haripriya led, and during COVID, to avoid spreading COVID when they reopened, they adopted these things on the right, which are standard in the West, but weren't at Aravind. So you can then go back and look at, did that improve endophthalmitis? And the answer is it did not. So it means we could move ourselves to all the things on the left, including multiple patients in the OR, and not expect endophthalmitis to increase. COVID also gave us these 5 studies that showed that it's virtually impossible to aerosolize microorganisms with ultrasound and phaco. Again, makes sense because that AC is just filled with sterile irrigation fluid. And this is a study led by Dr. Venkatesh's group, in which we cultured all of these things that are reused. And he'll probably tell you they reuse the same handpiece and tubing and cassette all day long. And if you then culture at the end of the day, more than 3,000 cultures, nothing was positive. So to answer this question, or to look at it, is it dangerous to reuse things? We gave you the expert opinion, which is the surgeons. We've got in vitro data, that huge 10 million patient study. We've got the environmental study, and we've got microbiology. And I guess you could say it doesn't prove there's zero risk, but we can't find any risk that would warrant not allowing ever anything to be reused. So as I look at it, this is what we need to do. There's 3 things. We have to ourselves be educated, and we can do things differently. And then we have industry. They need to do this. And then regulatory agencies need to understand that eye surgery is different from general surgery and orthopedics. So we have founded a coalition called AIOS2025, and it is co-anchored by ASCRS, ESCRS, and the Academy. Those are the sponsors, and we've just now added EU Retina, the largest retina society in Europe. Each society has its own committee, its own page on this. But to this now, we've added 53 global member societies as part of this coalition, all devoted to collaborating on reducing our carbon footprint. And it spans the world. It includes, here's our member list. So there you see AIOS, and Venki is one of the reps, and then APAO. We have an advisory board, we have an editorial board, which is going to be reorganized. It's half European, half American. We welcome Asians. We have our own app. And this is where you can come to find the latest in publications, latest in news, and then whether it's the OR, the clinic, drug waste, and then the section on low to middle income countries, we have sections really to highlight what can be done in each of these areas. And wherever possible, we have the evidence linked to it, because if you want to go to your hospital to have something changed, you need evidence. You can't just say, we want to change this. We're building a retina section, and this is very important because intravitreal injections, the numbers are staggering in terms of how many are being done, and there's huge waste there. Now, this surgical facility pledge is something I would love everyone here to do. And it's like signing a petition. No one's going to ask you to follow up. But these are 7 things that we can all do now to cut our carbon footprint. And if you go to isustain.org, you'll see the 7-point pledge. And almost every one of these saves money. Some of this is just education. This is ESCRS created this tool that we have online where it helps you understand how much waste is generated by each item. So if you're not using it every time, hey, get rid of it. save some money as well as waste. This is reusing topical drugs, the necessity of, you don't need a full body gown, you just use a plastic drape. This is using reusable things, using alcohol-based surgical scrub. And we would love if you could get your facility to just put the name on there. It's a petition. No one's going to check on that, but then we add you to this banner. And we would love to add your facility here, kind of like signing a petition that says, hey, we are committed to looking at ways to save money and carbon footprint by eliminating things that aren't necessary. And if we can all do that. We succeeded at getting the academy to including sustainability in the basic science course. And we now have the American Board of Ophthalmology adding sustainability questions to the board exam. So this now becomes something that residents should learn about because it affects our patients. All right, the second thing is industry, all right? So we have a section called Industry Initiatives. We put together an industry advisory board because we think that collaboration is important, but very importantly, though, we don't accept any money from industry for the website. It's covered by those 4 societies because we don't want any conflict of interest. One of the things, easy, there is no reason there should be a paper instruction for use with every IOL cartridge and IOL. Come on. So we put a multi-society position paper calling for EIFU across the board for ophthalmology, but prioritizing those things used on every case. It's a little complicated because there are regulations and so forth, but we're working on that. And all of our position papers, we have 3 now, are there, okay? So this is, again, a toolkit because if you want to, talk to your facility about short cycle flash sterilization, there's a position paper for that. This is IOL packaging. This is a study that John Hovannesi and I did, and this is just showing the huge variation in the packaging weight and sizes of the boxes for IOLs. That's obviously bigger with a preloaded system, and this is working. One company that makes the adjustable lens, they came out with a smaller box because they had the biggest box, and we told them that. Alcon is you're going to see already a smaller box that's going to get even smaller next year. I switched to the only phaco machine in the United States that allows us to use reusable tubing. We have to process it and autoclave it. But now 1 cassette takes the place of 20 plastic cassettes and packaging there. But what we're really calling for, and we're working on a position paper, calling for the phaco industry to get away from this throw it out each time. This could be autoclavable, but the best thing would be to have an all-day cassette that you don't take off and have them charge a click fee or do something so that they can collect a reasonable amount of revenue, but they're going to save so much in terms of manufacture costs, raw materials, shipping, and packaging that they should be savings that they can pass along to us. They can make a similar profit, but why have to throw this plastic, which is not recyclable, goes into landfill, and becomes part of the microplastic problem we have. Regulatory is the last, and that's the trickiest question. And, we get into problems because by default, we have to follow general regulations that are set up for general surgery. The classic one was when we were told we could not use flash or short cycle sterilization for cataract instruments, meaning a 1-hour wrapped sterile cycle for every tray. We'd need 20 to 30 trays just to get through the day. Nick Mamelis and I chaired a task force where we actually wrote ophthalmology-specific guidelines. It took us 3 years to do this, but you got to do it because if you don't have your own guidelines, you have to follow the others. So again, this is a position paper on iSustain. It turns out that there is just no evidence behind most of these guidelines. It's expert committees who obviously have a bias because they're nursing infection control nurses. This is a classic what we call eminence versus evidence-based. But there are regulations, so we have to come up with evidence, like some of the ones I just showed you generated from Aravind. And then you have hospital regulations, and they're worried about liability and things like that. So you just need to go up with that. This is documenting the cost as well as the carbon footprint of unused topical drops. And yet there are many hospitals that require you to throw it out after a single use. So we had to generate our own position paper saying that everyone should, unless you contaminate the tip, reuse the bottle until the date of expiration. We were able to get the government, it's called Medicare in the United States, to change the rule where they said you can't keep a bottle for more than 30 days. Now we can keep it until the date of expiration. Alrighty, if it's frozen up here, thank you. Yeah, can you just let me, since the last course went over half an hour, can you free up the, do I have to, thank you. All right, so the label, here's the other big problem. In order to be able to reuse something, the company has to show that it's safe to use it 20 times, and then it can be labeled, you can reuse it 10 times. All right, so that's hard. But if the company doesn't do that, you by default get a single-use label. And of course, look, what reason would a company have to go through all that, to validate that? But then the default is you can never reuse it. That's a problem. So I organized both the Academy and the ASRS to talk to different people at the FDA. And we said, you need a new label. You know, tell us when we shouldn't reuse it. I want to know that. Tell us if the company validated that you can reuse it. But the default should be nobody's validated reuse. Then it becomes my decision to do it off-label. And that's what we're trying to push. It allows for off-label use. This is my congresswoman who's very influential, and with her help, we met with CMS to try to get some relief. So this is the tough part, is working, you know, on the regulatory side. So I'm going to end by basically saying, you know, we all know usually ophthalmology, no one cares about that in terms of general medicine, but our volumes are staggering. And so we actually have an amazing opportunity as well as an obligation because of the volumes, because of knowing from the Yerevan studies that it's safe to reuse things, you know, to do something, you know, about that. And so as we get the next speaker up, you know, Dr. Venkatesh and I go back 22 years, and I have learned so many things from Yerevan. Dr. Ravi's here. We also met 22 years ago. And I didn't know anything about this until they did the studies. So they kind of, like a lot of things, got me started on this. And thank you all for being here. Thank you.
Yeah.
I'd like to introduce Wendy C. She's one of the young ophthalmologists from APAO. She's from Malaysia. And Wendy and I have been involved with trying to do this survey for the APAO membership. So you're going to be the first to hear. This is a preliminary results.
Thank you, Dr. Chang. Thank you for this opportunity to speak. I'll be presenting, not this. No, not this. Yes, this. A survey of Asia-Pacific Academy of Ophthalmology's APAO's members' attitude towards oral waste and sustainability effort. So you guys must have known that a cataract surgery in the UK generates the equivalent amount of carbon dioxide emission equivalent to driving a car for 500 kilometers, and that is 20 times more than a cataract surgery done in India. So this creates a deep concern towards our work as an ophthalmic surgeon to the environment, the impact that we are doing to the environment. We all know that there are two sustainable surveys as conducted in the North America and European in 2020 and 2023 respectively. It reveals a strong willingness amongst the ophthalmic surgeons to adopt a more sustainable practices in the OR But what about the Asia-Pacific ophthalmologists? What do we feel about it? So to answer that, a special task force has been formed in 2024. I thank all these people, especially Dr. David Chang, for their help and support in this project. An online survey was distributed to the members of APAO via emails from February to March 2025. This is just the preliminary data. The survey is currently still ongoing. It is available in English, and we translated it to Mandarin and Japanese. Similar questionnaire that were used in the previous surveys were also used in this survey to allow for direct regional comparison. This is the result. We have close to 2,000 respondents coming from Japan, Indonesia, China, the Philippines, Malaysia, and etc. Most of them have 10 years of experience, high cataract volume surgeons, they work in a public or government hospitals, and majorities are male. So this is the result. Close to 94% are concerned about global warming and climate change. And this data is closely resemblance to our Western counterparts in the previous surveys. When we ask what is the perceived driver of OR waste, 2/3 agrees that manufacturers play an important role in reducing OR waste. We want the manufacturer to offer more reusable instruments as an option and to consider the environmental impact when designing and packaging their instruments. More than 60% agrees that regulatory body should allow surgeons discretion in reusing these medical supplies, and they want medical societies to advocate for it. And of course, we do want more clinical studies to show the safety of reusing these medical items and supplies. And this is an interesting one. This data shows that there is a higher proportion of respondents in the Asia Pacific who are already currently reusing medical supplies in the Asia. As you can see, more than 2/3 are reusing phaco tips and IA tips, 40% both the phaco and IA tips. More than half are already reusing irrigation solution and bottles. For those who are currently not reusing, 1 in 5, around 20%, are willing to consider doing so. So the same goes for intraocular pharmaceuticals in cataract surgeries. Globally, concerns from endophthalmitis and malpractice liability significantly reduce the willingness of reusing these supplies on multiple patients. And comparison across the region, the same factors such as cost saving and environmental consideration increase the willingness of ophthalmic surgeons to reuse supplies on multiple patients. Major factors that drive the single-use instrument in our fields are patient factor, 80%, performance of the instruments, and yeah, we don't want to get sued. So if you could choose an instrument with equal functionality, equal performance, and equal cost, 65% of the APAO surgeons would prefer to use reusable instruments. And this is incomparable with the European surgeons. 77% of them will prefer to use reusable instruments. So in conclusion, in this preliminary survey of close to 2,000 respondents, the data closely similar to our Western friends. Almost half of those are already reusing and willing to reuse medical supplies on multiple patients. We rank pretty similarly in our factors influencing our willingness to reuse these medical supplies. And this preliminary data shows potentially that there is a strong consensus that ophthalmologists worldwide are very concerned about global warming and climate change. With that, I thank you.
Thank you, Wendy. I think it's still a preliminary, but we'll have results being published soon. But we have next 4 talks coming up. So first it will be, as an ophthalmologist, why sustainability is important. Dr. Priya.
At the outset, I would like to thank Dr. Venkatesh and Dr. David Chang for having me here. So, well, today I'm going to be covering just a brief cover-up. I think a lot has been discussed about the sustainability in ophthalmology. And I was so glad to see this email coming up, you know. Our own society, along in association with APO, it supports the sustainability, and that is really very heartwarming to see. As Dr. David Chang said, he is a pioneer, you know. He brings all the ophthalmologists and the industry together on a single platform. And we regularly have meetings at the ACRS and the Academy, and even at the EACRS for the sustainability. And it's a great platform to bring everybody together into this noble cause. And just not to say anything, but we all know that the World Health Organization has come up with that. We all know that climate change, it's very important, and sustainability we can contribute to sustainability as much as we can from our end, because everything at the end of the day is intertwined. So strengthening of the health infrastructure, especially in the developing countries, that's very crucial to to reduce the greenhouse emissions. And we have a different concept coming up from the West, decreasing the OR waste, etc., towards that can contribute towards sustainability and also towards the climate change. So basically, this was the study by Dr. Chang, and with an online survey of more than 1,300 cataract surgeons, this is what they came to conclusion, that at least 93%, everybody felt that the OR room waste is too much, it's excessive, and it needs to be reduced. Surprisingly, we in our country, in India, when we start comparing ourselves to what the waste is generated in the West is quite less as compared to that. And Dr. Venkatesh and his team, they have done an incredible job by documenting their study about the OR waste and other reusable things that can actually be reused during the surgery. And 78% opined that there was more reuse of supplies are warranted, with 90% they were actually concerned about global warming, and 87% wanted some sort of reduction in the surgical carbon footprint. So that's actually motivating. There are various challenges, when we come across this. We all know that, the reliance on a single-use instruments, because, that's a very thin line. Actually, not everybody is so keen to reuse these disposable instruments, because at the end of the day, there is another aspect which is known as endophthalmitis. That is one thing which all the surgeons are so scared of, and actually they should be scared of. But, you have to strike a balance between getting things done. Maybe if you can reuse some of the things by sterilizing them, then it should definitely be done. Waste from packaging, as it has already been highlighted, you can have those QR codes and IF views, information for use. You can just scan that and you can get all the information that you actually want to read, and the unused medication. So what do you do actually about it? So these are some of the sustainable surgical practices which you should be actually concerned about it. About reusing the surgical tools, the efficient use of resources, and, the minimal packaging. These are the three backbones of this. The concept of sustainability to go ahead with this, and implementing the energy efficient practices. This is the renewable energy, the solar, wind power, eco-friendly systems, the LED lights, motion sensors, etc. Whatever energy efficient practices that we can employ into our system, that would phenomenally change the paradigm of the future management and future decreasing the burden on the climate. So the sustainable eyewear, it has been recommended. Many people, you have those monthly disposable contact lenses over daily disposable. Maybe if somewhere down the line something can be recycled, reused, and using the sustainable energy in manufacturing the units. Telemedicine and digital transformation, this is one another aspect, to decrease the travel cost, because every time a patient visits to you, with the, suppose if you do a cataract surgery, maybe you have about 3 to 4 visits, at least over a period of 2 months coming up. So maybe if you can do a teleconsultation or maintaining the digital records, giving e-prescription. So this is all, at the end of the day, it reduces the emission. Patient is not traveling to you. So even that helps in reducing the footprint. So these are some of the things, which are all intertwined, and we need to cut out certain guidelines to put forward to how we can actually go ahead with these things for a better future, not only for our generation, but also for the next generation. So the procurement and waste management. So this is one of the most important and the essential aspects, of how to go ahead with this. We need to prioritize managing the waste, etc. And we all know that, we saw a beautiful video which was made by Arvind Group, Dr. Venkatesh, which was shown in the ASCRS. It was really enlightening to see that, how things can actually be made much more sustainable in our practices by, having an efficient cycle of use of material and, not even wasting whatever the waste comes up from the OR, even reusing that somewhere down the line. So I think these things, they will go a long way, and engaging the healthcare professionals, having training programs, workshop, and having green committees, teams in hospitals that, they can implement the eco-friendly practices, creating a lot of patient awareness by promoting sustainable eye care habits, and, for example, as Dr. Chang said, getting yourself registered, taking a pledge, putting yourself up onto that, that actually motivates you and also your other teammates whom you get onto the same platform. So actually, when you all start thinking in the same direction, things start making difference. Although it might be a little difference, but over a period of time, all these things keep on complying, and it actually makes a lot of difference when everybody moves into the same direction. So I think, just to conclude, I would say that sustainability does not compromise any patient care. So that's the one of the most important things. And integrating the reusable instruments, energy efficiency, digital health, and a sustainable sourcing, it makes a significant difference. And we all need to adopt at least one sustainable change in our practice. So I think I would like to conclude with this. So thank you so much.
Thank you, Priya. I think it was very comprehensive. Not thinking about what you do, but I think beyond, for the next 5 years, 10 years, we have to think of teleconnectivity, telemedicine, reducing the travel burden of patients, staff. All that is very important. So we have my colleague, Dr. Divya. She is the Executive Director of Lions Aravind Institute of Community Ophthalmology, where they have a systems approach for everything. And she's going to share how systematically, we can have a good service design to kind of sustainable practice.
Thank you, Dr. Venkatesh. So this talk, before I get into this, I consider myself kind of someone who cares about the environment, but even someone like me was kind of unaware about some important truths about India and just traveling in India. India is contributing to is fourth in contributing to carbon emissions, and our quality of the air, is pretty dismal. So while this is appalling, you may be wondering why I'm talking about transport so much. Because if you look at service design and the amount we, as well as our patients, travel, it really warrants that we take a hard look at the way we are designing services. When patients come to seek care, it's a long process. There are several steps in this. Now, if we're using an appointment system, you'll know that at every stage, if the patient comes in, he has to make multiple visits because he has to then fix an appointment to see a specialist. He has to fix an appointment for treatment. But if we can provide on-demand care, and if we can complete everything in one visit, then we are able to a great extent, remove a lot of these unnecessary travel for patients. You may not have thought of this as part of ophthalmology, but we are clearly contributing to carbon emissions when we design services differently. Can we rationalize follow-up visits? How many visits do we have patients coming back after cataract surgery? Or to pick up a pair of glasses? Do they need to make multiple visits? All of these contribute to carbon emissions. So can we rationalize this and remove some of these visits? Can more of these visits be made local? So can you have your preliminary examination done closer to the patient's home, say at a primary care center? Today, telemedicine is there. We have no excuse to do this. And similarly, follow-up visits. At our Pondicherry Center, and now in many of our other centers, we're having patients who come in from the vision centers. They get surgery. When they are referred for surgery, they come in. All the investigations are done quite early in the morning so that they can get their surgery. They're kept on observation for about 4 to 5 hours. The discharge vision is done right then, and they're sent home. They don't come back for a follow-up visit. Where we require them to come for a follow-up visit, we also, if it's not complicated, we have them do it over telemedicine at the vision center, which is closer to their homes. So can we see how we can shift all of this to be more local as much as possible? And we've seen that there is no effect on the outcomes. Slowly, can these even be replaced to something that the patient does within the comfort of their own home? Are we investing on these technological advances? And where possible, can we also look at how we can aggregate transport? I'll talk about that in a bit. So we definitely need to look into how we can go into even more reducing transport for patients. And if you look at our vision centers, this is what I was talking about earlier. These are rented facilities in rural villages. Most of the patients come from within a 10-kilometer radius, so that's the maximum that most of these patients travel to seek care. Every patient pays about 20 rupees. You'll see that they get a comprehensive eye exam. There's a standard clinical protocol, and all patients receive a complete eye examination. These are trained vision technicians, kind of like a equivalent of an optometrist. And depending on the patient's complaints and depending on the patient's age and other history, standard workup is done, like you can see. They undergo IOP testing if they're over 40. They get a BP exam. We're looking for diabetes. Every patient above 30, a fundus examination is also done. And the main thing is we have an electronic medical record. So all these fundus images are now attached to this, and every patient gets to see a doctor through telemedicine. And as he mentioned earlier, the EMR makes all of this possible. The electronic medical record makes all of this possible. The patient, this is live. This is very important. This is a live, there is no waiting period for the doctor to interpret the results. So everything is on demand. So if the patient needs glasses, this is also available. So for all of this, for the service design to really work, it's not just about setting up a vision center. Each of our vision centers sees about, on an average, about 30 patients a day. And this is because the care is comprehensive, it is complete, it is ensured that it is provided in a relevant way and instant. It's not about deferring cases, it's not about having the patient wait to see a specialist. Again, it's local for the patient, so they're able to access it. And of course, like anything else, services have to be responsive to the patient's needs and expectations. I want to also share this. I was in rural, this is the most remote place I think I've been to in rural Assam, where there is a cancer care center. This has got nothing to do with eye care, but I just wanted to share that they have an ICU, an intensive care unit, but they can't afford to have intensivists, having super specialty care there. But they have a tele-ICU, where they have cloud physicians who are kind of watching. It's AI-enabled, so the AI is watching the monitors, and it alerts the physicians. So these patients are getting excellent intensive care. So you really have super specialty care delivered at remote locations, and it may be even more effective than having them there in person. Greatly reduces the transport burden, and for specialists, they're able to achieve scale, because if you had, rather than having to be there in person. And again, just a small look at our outreach camps, which we do about 3,000 such comprehensive camps in the villages, again, taking care to the people, which means about 12 of our staff would actually travel out to the villages. But then you can, just within reach of their homes, you're able to screen 200 patients, again, reducing the transport burden. And about 60 patients from each of these camps are brought back over for surgery. And again, at these camps, you'll see it's, again, comprehensive. So if, for example, those requiring refraction, a full refractive estimation is done. Those requiring prescriptions are given, the doctor prescribes it there, and the patient is able to get the glasses within about 20 minutes, 20 to 30 minutes. They're able to get custom-made spectacles. Patients pay for it. Patients pay full price. It's not subsidized. It's not free. So no income can actually subsidize some of your other services. We have very high uptake. So we have about 85% uptake on glasses, versus if the patients had to get these glasses on their own. A study that we did show that less than a third of them would actually do it. And again, they would have to travel for it. You'll see in a year, we handle 6 million visits, out of which 1 million is done through teleconsultation. Imagine the amount of carbon emission that's been saved, that has been avoided through this. I just want to now switch to the design of our buildings. I think these spaces are also very important. So many of the Aravind buildings are deliberately designed to reduce the energy consumption. So you'll see the spaces maximize natural ventilation and light. We do not air condition the entire space. We minimize the zones that have AC. The buildings are oriented in such a way so that we're not getting the full sunlight. So they're kind of built in a different direction than the path of the sun. And we also, you'll see many of these buildings have these shades, that really cut out the direct sunlight. We have a lot of atriums like this, and we try to bring in some greenery into the building. This is our newest building that we're inaugurating 2 weeks from now. And you'll see that, you can see how much of light is being brought in. A lot of sunlight is being brought in. And none of these spaces that you're seeing right now will be air conditioned. So just these tall atriums, there's enough ventilation here. Only clinics will be air conditioned. And it's very, very comfortable spaces for patients to go around, even in a place like India. And the energy that we use, we try to use clean energy as much as possible. So all our terraces will be filled with the solar panels. This is a drone shot of our Pondicherry hospital. You'll see that the hospital as well as the parking tops are, have the panels. And about 65% of the Pondicherry hospital's consumption comes from its own solar panels. Okay, and about 90% of Aravind runs on clean energy. Some of it comes through its own solar panels, but the rest is bought from energy farms, like solar energy farms or wind farms. So we try to maximize, try to ensure that the energy we consume is clean. And very interestingly, we've kind of shifted to energy efficient appliances. We use energy efficient lights, fans, all the, even our AC plants, all of these have become energy efficient. The company that's done this for us is getting its pay. We don't pay them. Instead, they take a percentage of the difference in the electricity saving that Aravind is making. So you can imagine how much we've actually been spending on energy. If a company can live off of that, can profit out of that. So you'll see all of these lights are changed. Very importantly, water is a huge, we don't think much about water, but water consumption really contributes to pollution in many different ways. And minimizing water usage is one of the things, and you saw that in Dr. Chang's presentation as well. So here we use waterless urinals in the toilets at Aravind. We also have, all of our new centers have the decentralized wastewater treatment plant, which does not use chemicals or is not very energy intensive. In a very natural way that's kind to the environment, it's able to treat the water. So all of these our new facilities are able to treat over 90% of the water that is used in the hospital. The recycled water is used for flushing, for gardening, and it's used for the AC cooling towers. And we also invest in building these rainwater sumps. And the water is also used, the recycled water is used for our gardens, and many of our hospital gardens have award-winning features. With year after year, they get these, their gardens are award-winning. So I just want to conclude saying that when we design for sustainability, we're also finding that our costs are low, our profits are better, and most importantly, we're having a very patient-centered design as well as a people-centered design. So thank you for the opportunity, sir.
Thank you, Divya, for highlighting how the service design is so important. All these new buildings. So not this presentation, not this. So Dr. Reddy. So I have two of my heroes, who are passionate of sustainability. And somebody in his regular practice. So I should know how in a regular, normal, your own clinic or in your own hospital, how do you practice that? And in an institute, how do we practice? So first we'll have Dr. Reddy, who will be talking about how he practices sustainability.
Thank you, Dr. Venkatesh. And I think this is a mindset. The practice of sustainability is a mindset. And if we go one generation back to our parents or grandparents, everything was sustainable. Now, over a period of time, we have changed to a Western model, which, again, we are going back. The West is also going back with us to make sure our lifestyles are sustainable. We know this, that gases released into the atmosphere due to various human activities is trapping heat and making Earth warmer, and our lives are threatened. Carbon dioxide, nitrous oxide, methane, and chlorofluorocarbons are the main sources of this warming climate. And then 5% of emissions are due to healthcare worldwide, and as David Chang was saying, that 10% in the US are due to healthcare emissions. Our Hippocratic oath is to do no harm, both for the patient and the planet, and we should remind ourselves of that. We have to decrease environmental footprint personally and professionally. Profession comes later. Personally, we need to do it in our lifestyles. We should be convinced that this is the way to go for our children, grandchildren. And besides global warming, it's also the plastic, pesticides, which we are contaminating the earth should also be part of that crusade. So the basic principles in our lives and in our professional as well as personal lives should be to reduce, reuse, and recycle. So in the outpatient service, as was discussed earlier, but I'd like to emphasize, avoid or decrease patient visits. Sometimes, majority of the times, our economic reasons come into the picture when we are doing our practices, but I think that's not the issue. We have to follow our Hippocratic oath and make sure that we do help the patients rather than harm them. And then I've seen some of our colleagues calling patients 6 monthly, but I think it doesn't make sense. Yearly or 2 yearly follow-up visits are enough. We have to revisit this and see really how many visits we really need to provide of appropriate health care and teleconsultation if appropriate. During COVID times, because normally I used to call my patients 1 day, 1 week, and 1 month later for cataract surgery. But during COVID, because it was difficult to call them, we used to call them a month later. And I found that in the last 3-4 years, it didn't make a difference. You can call them on the first day, and then if they have a problem, we can tell them that these are the signs which you need to be aware of, and then come when needed. So that way, each patient had 1 visit less, and it's appropriate environmental and personal advantage. And then electronic medical records have already been shown. All of us can go even in our clinics. It's easier, it's less expensive. Fortunately, all environmental practices are also cost us less, both for the patient and for us. And if you're giving a plastic file, you can charge for that, because every visit a patient wants a plastic file. You can avoid that. And the patients can have, nowadays, most of them don't keep a copy. You can have them in their mobiles by giving them a soft copy of the report at the end of the visit. Decreasing prescription of glasses, because there's a self-interest involved both for the doctor, for the optician, and then they tend to, even for the 0.25 change, 0.5 change, when most of the time it's not necessary, we prescribe glasses, which are encouraging use, of the new materials. So for that, we can advise, because most of the times the patient says, doctor, is it really necessary? Our economic considerations do not step in, only change if needed. And medications and eye drops also similarly, and now we've discussed about that we can use till the end of their life. And otherwise, we have already drilled for so many years into the patients that they can use only for a month. Even costly drugs, they just keep throwing away. So that we need to stop. And to encourage sustainability and to create a mindset amongst patients, we can have a container in our hospitals regarding used spectacles, drops, bottles for recycling, and probably give them a small 10 rupee, 20 rupee incentive for them to return them back, not basically for the cost, but for the environmental protection. Reusable theater linen. I've been trained in Aravind earlier. So eye towels, caps, gowns, so many of them we tend to reuse and create a huge amount of waste, which we can safely reuse them. Minimal use of betadine and chemicals. Iodine is one of the deadly chemicals which will contaminate the environment. We have to sensitize our staff to use a minimum use. And then glass syringes, unfortunately, I've been using for so many years, but now they've stopped making glass syringes. You can stop so many hundreds of plastic syringes by just autoclaving them along with the instruments. But when I inquired, they said that glass syringes are not being made now. So I think we can try to advocate for that causes. And then many things, cannulas, iris hooks, many of them can be autoclaved and reused. Ask the industry to recycle phaco tubings, and one of the major industries, when I asked, they said that the country had said it's a municipality's problem. That was the answer I got. So that's ridiculous. And then we have to make sure that these people take back their plastic and then reuse it. And then, and as David Chang was saying, we can use reusable tubings in certain machines. And then industry has a reason there, and we need to make sure that they don't utilize it appropriately. And then every technology should have a green audit also. Like if we are thinking of, say, femtocataract, how much more, especially in India and developing countries, if you are trying to encourage femtocataracts or whatever, the consequences, both in terms of cost and waste which is generated, it's appropriate in certain conditions. I think we should not use it appropriately rather than say that it is good for everybody. Staff motivation, discourage single-use plastics. And last time during our Diwali thing, we distributed steel water bottles for all the staff so that they can reuse it rather than use more of plastic glasses. And then decrease use of water, electricity, AC temperature settings. So majority of the times they have set to 18 degrees or something, but appropriately 22, 23, 24 are the ones. We, all of us, just to make a point, all of us use layered clothes and then keep the temperature at 20 or 18. And for tropical climates, we don't need 3-piece suits, 4-piece suits. So we need to sort of have appropriate clothing. Paper usage can be decreased or double-sided can be used. Segregation and appropriate disposal of all waste, including e-waste. Equipment can be repaired in most cases. Nowadays, the trend is to use newer equipment rather than repair them, and avoid harmful chemicals in your pest control and cleaning procedures. Building designs have been already emphasized on, which is really nice, but you don't need extensive spaces for clinics. Appropriate amount of space is enough because it increases the cost of everything, including maintenance, planting trees, solar panels. I've been trying to source for ethanol generators, but they're not available. I think we can ask the industry where ethanol can be used for generators for our energy backup. And then use of electrical vehicles, all of us know. And then eco-friendly designs has been discussed. Water recharging has been discussed. Sharing equipment. We have a group practice wherein for the last 25 years, a lot of private practitioners come together. We have 20 or 25 people who use femtocataract, which goes to each clinic. We use refractive surgery, which we have a common facility, and all of us get our patients and pool them and use it. So all this helps in decreasing the environmental impact of technology. Lifestyles, of course, plant-based foods, online meetings, and climate-friendly clothing, as I was suggesting, would be of real help. But it's a mindset. All of us should think of that. Thank you very much for this opportunity, Dr. Venkatesh and AIOS.
Thank you, Reddy. I think we will see how an organization practices that. Now I have another hero, Dr. Uday, who will be sharing how they practice in a slightly bigger organization.
Good afternoon, friends, and thanks to Dr. Venkatesh and AIOS for giving us this opportunity to talk about our effort at reducing carbon emission. I'm very happy to tell you that we created the first ever platinum rated green building in healthcare sector in Gujarat. So we wanted to remain climate friendly, and that really helps the UN Sustainable Development Goals of SDG 6, 7, 9, 12 and 13. So what we are doing through our activities, as Divya has also mentioned, trying to finish all the activities in one day, including referral to subspecialty. We also perform same-day surgeries. We ask patients to go to vision centers for follow-up, and even we allow them follow-up phone calls also. So all these helps in reducing the patient visits to the headquarters. We deliver tailor-made glasses on the same day, almost 80-90%. We reuse the material by re-sterilizing, and we use EMR that reduces the usage of paper. Through our outreach activities, we have developed a data entry app. So all our outreach activities, including iCamp or vision, the field work, etc., door-to-door activity, are all paperless. So that also saves cutting trees. even our ROP screening is reported online, so that the parents get the reports on the same day using e-bikes and CNG vehicles. So through our vision centers, we see about 30,000 patients annually, and that saves minimum 1,400 tons of carbon emission, even if we consider all patients traveling by public transport. We use 5 CNG vehicles which run about 4 lakh plus kilometers last year. That saves about 78 tons of carbon emission. We hire all local staff for vision centers and for field work, and that also saves transportation and through that carbon emission. In terms of creating the physical infrastructure, we have installed 5,100 liters solar water heater system. That saves about 82 tons of carbon, and it gives us 82 tons of carbon credit every year. All our lighting are T5 LED lights. All our bulbs are LED. All fans are energy efficient fans, and all our air conditioners are 5-star rated air conditioners. All these save a lot of carbon emission over the year. We installed 28 kilowatt solar electrification rooftop panels. That saves about 15 metric tons of carbon emission. We use solar heated water for autoclave machine and laundry, so that also saves on electricity consumption. We installed energy meter so that we can keep a track of how much energy we are using and where we can further reduce through this monitoring. We installed a biogas plant, and that generates about 400 plus kilograms of LPG every year. We use box type solar cooker for cooking, and we use steam cooking for rice, dal and vegetables. In terms of water conservation, there's a water recharge borewell created which helps bringing up the water tables, underground water table. We use waterless urinals to save fresh water usage. There's a 2 lakh liter capacity rainwater harvesting tank, and we use that water for cooking and drinking purpose for the whole building over the year. We have installed decentralized wastewater treatment system, as Divya also mentioned, and that water is used for gardening and flushing purpose. We use exhaust from air conditioners for our autoclave machine, which is almost as good as distilled water quality. Reused water being used for gardening. All our water taps have filters installed that makes them low flow faucets, so that also reduces the consumption of water to a great extent. And believe me, this flow is definitely enough for our washing purpose. We have installed water meter also. That again keeps a check on water utilization. When we created the building, we installed bamboo curtains that will reduce bamboo curtains on the windows that reduces the transmission of heat to the inside of the building. This is a solar passive design that saves about 5% of the energy consumption. We used aerated blocks for construction purpose. That also reduces the inside temperature, and with that the need for cooling is reduced. The direction of entry of light and air, so there is no need for lighting during daytime. There are sprinklers installed in the atrium, so that brings down the temperature, particularly during the summer months. That reduces the need for cooling. We use 100% second-hand teak wood, so no fresh cutting of trees was done when we constructed our buildings. Used natural stones, so no tiles are used. The outside walls are cladded with cement sheets. That again reduces the temperature inside, and with that the need for cooling is reduced. And a China mosaic on top of the building on the terrace that reduces the heat transmission to the inside of the building. So all these activities particularly will reduce the need for usage of energy to reduce temperatures inside. And we won the Immersion Cup award for having done all these activities in the building. So next steps forward, we are almost ready with our new campus. We may be shifting in a month from now, and we are targeting a carbon neutral status for the whole campus. It will be a green campus. So what we have done is we created high ventilation areas, as Divya mentioned. Light and wind circulation is managed in such a way that waiting area does not need lighting, or no air conditioners are installed in the waiting areas. We'll be installing 0.3 megawatt solar rooftop system in the new campus. All our air conditioners are inverter ACs, 100% LED lights, sensor-based lighting in passages, and all our fans are BLDC fans. So all these in total will reduce energy consumption. Again, in the new campus also we have a rainwater harvesting 2 lakh liter capacity tank that will be used for cooking and drinking purpose. There are 15 water recharge borewells created, so we'll be able to give back to the earth the rainwater that will be surplus for us. And public use faucets, the water taps are all auto turn off faucets, so that the wastage of water will be reduced. And all the appliances that we have purchased are IGBC approved. So again, we'll be able to reduce the energy consumption. In near future, we want to convert our vision centers also into green centers. We want to start using e-vehicles. We want to install windmill for pumping of water. We'll be installing waterless urinals in the new campus. And we'll be encouraging our staff to walk down to the workplace from the town at least once in a week. People use vehicles just for half a kilometer or a 1 kilometer walk. So we're trying to encourage our staff also. The challenge is in all these activities is there's a one-time cost which is quite higher as compared to the routine material that we use. Naturally, our priority is running the hospital, so maintaining all these green activities is at times difficult, but we could retain our platinum status when we went in for renewal in the current building. Being in rural area, transportation distances are more and technical support is far away, making it little difficult to maintain, but it's our commitment to do it, and so we do it. Some usage of plastic and other material is inevitable, particularly inside the operating room. Understanding among staff needs great deal of improvement. So some wastage of electricity, water and paper continues, but with that our efforts need to continue to educate all these people, as Dr. David Chang also told us. So it's a journey that continues, and we will continue our journey on the same path. Thank you so much.
So I think you can all feel that passion. I'm sure everyone has got that passion in them, but somewhere we need to start practicing small. I think I'll maybe in the next few minutes, I'll not take 10 minutes, I'll share what, can you put that on the screen? Okay. So how are we into this? I'm not going to talk about the sustainability goals, but what Lancet is saying is climate change is the biggest global health threat, and they say that tackling that change could be the greatest opportunity for us. So one side, we have a threat, and the other side we have an opportunity, and every one of us has that opportunity, like beautifully highlighted by some of my colleagues who are already practicing that. These are the 7 elements. Many of them are now seeing how they can practice all that. Energy efficiency, green building design, alternate energy generation, whenever possible getting clean energy, transportation, like what Dr. Uday was saying, making his staff walk to the hospital. I'm sure they're not walking to some other hospital on the way, but making sure that we reduce the transportation. In all our new facilities, like we have the quarters within the campus so that they can just walk a few minutes to reach the facility. Food is a very important aspect. People touched upon it, and waste and water. But what we see is, whenever we talk about sustainability and resilience, there are a lot of things involved. When we take our operating room, electrical, capital goods, lot of disposable versus single use, a lot of reusable things which need to be sterilized, where there's a lot of water usage, lighting and ventilation. But more than that, we have so many things which bothers us. The contracts, the payment and reimbursement, the training and local habits, policies and regulations. But what we see that we see it as a systems issue. And that is what Divya was also highlighting. Now, how do you solve this systematically, especially in healthcare? So that's where we have been running all these hospitals in south of India, mainly in Tamil Nadu and Pondicherry. Today, we see close to 20,000 patients. We do close to 2,500 surgeries. Lot of outreach, like what Divya was showing. But basically, now what we are seeing is, any facilities at Arvind is looking at these two buckets. One is the service design, which we already have, and the general aspects of it. Like any new infrastructure, we are looking at all these things. Are we having a green building? Are we putting everything energy efficient? Like Uday was beautifully showing, 5-star air handling units have to be energy efficient. Your LEDs, fans, they really make a lot of savings on your pocket. And looking at alternative source, like in Pondi, we are fortunate to have a good space to almost generate 70% from solar, and reducing travel, and a lot of times maintaining your equipment is very important. Now that you give a life to your equipments, and then looking at consumable procurement and things like that. So this is our beautiful Pondi facility. Now I show this drone shot to show how much of space we have to do the DWATS plant, which recycles 300,000 liters of water. We almost generate 70% of our electricity. Now the solar panels are now going back to the ground, which you see there. So we are now making sure that can we do 100% energy efficient through solar. So when you talk on service design, Divya covered a lot of things which we do in the outpatient, vision center, and outreach. But I am going to again focus on cataract surgery, which David Chang was already kind of pointing some of the work which we do. Because this is an area where you have a lot of capital equipments, your microscopes, phaco machines. Every day there are so much of consumables in the form of phaco lenses. And a lot of times you feel that there is a complex waste generated, but it is not complex. If you really look into it, waste, you will know it's not complex. I'll show you how we do it. But we have done a lot of systematic things over a period of last 50 years, I would say. The layout, the task shifting, standardizing things which happens, which is all kind of around reducing the waste and reusing a lot of things. But the most important thing is the twin table, which has really brought a lot of efficiency. By doing this, once you have efficiency, I think that the machine usage to the electricity, the staff, everything can be optimally used, and the time which you take for some of the work can be really reduced. So this is what we see on an annual basis. Any of the Arvind doctors does close to 1,500 to 2,000 surgeries. But more importantly, the stringent sterile protocols, sharing of supplies carefully, minimal use of single use, reusing the single-use instruments with very strict sterilization protocols, which is again evidence-based practice, and then segregating waste at the generation point or at the source. So this looks little complex, but if you see the blue ones are the ones which are being reused day in and day out. The yellow and the red is the real biomedical waste, and the green one is the recyclable waste. If you see my staff at the morning when they open the blades or the lenses or whatever, paper and plastic is separated at source. Once you start doing at source, you know that the waste generated is not complex. So all these blue ones either go for flash or a full cycle sterilization or a laundry, like what Dr. Reddy was saying. Your gowns, your caps, masks. The red and the yellow, which really goes into your red and blue, this is just 15% waste. Whereas the other waste, which you see as green, is almost 85%. And the blue ones are packed and reused after your full cycle. So we have done a lot of work to say that, we generate just 1/20th. But this work, we did recently to show evidence that you can reuse a lot of things safely. Again, a little bit of nudge from David Chang and few of my mentors, including Alan Robin. This work we did during the COVID time, because we thought we should not let a good crisis go waste. We were able to do a lot of microbiological investigations. So what we did was we looked at the profile of reused surgical instruments. So what we normally reuse, right? So we normally kind of send this for your flash sterilization. So all your instruments which you are using, your blade holders, your forceps, your lens holders, all these for SICS or phaco, they go to flash. And your phaco handpiece goes to flash. Your IA handpiece goes. But your phaco tip goes, but not the handpiece. So what we did was we looked at 3 different groups. So the first is all these things. The group 2 was the unsterilized, especially the phaco handpiece, which doesn't go after every case, only the tip goes. And then we looked, the third group was the residual fluids. Can we use the bag continuously is a big question. So we wanted to prove that you can use. And so we took the residual fluid from the BSS bags. So we had like close to 3,300 samples, and we observed for 7 days after doing microbiological testing. So no bacteria or fungal growth was not noted in any of those plates. And during the same period, no, we never had any endophthalmitis in a 6-week follow-up of these 3,200 plus surgeries. So this again, I mean, we have been doing these practices, but at least now we have evidence to say that, no, if you can carefully reuse this, what needs a flash can be flashed, what need not be flashed, continuously can you use it till the end of the day safely. And this is one work I think David Chang had highlighted, pre-COVID and during COVID. Not during COVID, lockdown, we followed what David Chang does in his operating room, no, which is always bothering me. Whenever I go and see there, no, why are you throwing like this? Venki, I have no other go. You have to give me evidence. And this is a period before COVID, no, January 2020 to 25th March, where we had some 56,000 surgeries. And then the group 2 was during the COVID time. Now, when we had all the regulations, even AIOC had a guidelines. Each patient was gowned, surgical gloves was changed, OR floors and counters were cleaned and mopped. Only one patient in the operating room. The next patient was waiting outside. And the same thing we did. No, we saw these 2 groups, and there was no difference in, again, endophthalmitis. No, that also clearly gives you an evidence that you can do the twin table practice carefully in an ophthalmic setup. And this is the work, no, this is a very interesting work. No, Casey Thale, who's now very closely working with many of my colleagues, I met her in one of the RO meetings, and she said she's an environmental engineer. I said, what do you do by environmental engineering? I also look at waste, hospital waste. And then she said, I want to look at cataract waste. And that's how this work came with a Fulbright fellowship, and where we found that, no, our footprint was just 25 kilometers. No, the carbon footprint was equal to traveling 25 kilometers, whereas in the Western world, it was 20 times higher. And that's what we gave a lot of evidence related to this some time back. And if you see like what Chang was showing, the infection rates were almost similar in the Western world and Aravind. So with less waste, no, can we have the same results? Yes. And this is what the waste, no, if you see between one phaco case, I mean, that's also Chang's OR many years back, but now I think it's getting reduced, and 100 cases here. But if you can segregate the waste like this, and this is what I mean, if you can get the paper, thick plastic, cardboard, small bottle, lens cover, thin plastic, it looks complex. But once you start segregating at source, I'll tell you, once you do this, like what they are doing now, in the morning, there are more buckets there in my operating room, but at the end of the day, I think you'll make a lot of profit from recycling, and you will also be very satisfied by recycling many of this kind of waste. So if you see that picture, you will see how. And this is a study we did for a period of a year to see how much weight we generate from each of these waste, and how much of money we could also make. We're close to 300,000 Indian rupees, which can take care of 2 people's salary in a year who do this kind of segregation work. And for the other waste together, it was like 500,000 Indian rupees, but only the theater waste was close to 300,000. So if we critically look into this, what is important is like what you're seeing, leaders like here, especially leaders like David Chang. He saw us work, but now he's taking it throughout the world, and bringing in all those changes, including getting into the AAO guidelines is amazing, where you are engaging the next generation. So it needs a high level of commitment, lot of engagement, both with the staff and also with our own customers, the patients. And this is what we do, at least in Pondi. What we do is we engage every one of the caregiver of our cataract patients. We have a fire officer who's so passionate of doing this work. He knows in and out about how much we generate solar, the recycling plant. So he shows that I'm going to take you on a green tour. It's going to take another 45 minutes. You're going to come with me. And you have to believe to see this, almost all the caregivers, they go with him in 2 different batches. One is between 9 to 9:45. The second is between 10 to 10:45. And he shows them what we do in the campus. how much water we recycle, how the DWATS plant works without chemicals. And then he shows us the nursery, and then the solar plant, 540 kilowatts, and how much you generate electricity, how much money the hospital saves, how can they implant the solar in their home, how the government gives them subsidy. He gives them an online form for them to apply for that. And at the end of the tour, many of my caregivers who give a feedback after the surgery say that the tour was no good, not the surgery. Not the care, but they say, I learned something today, from this particular gentleman. And then definitely, we are trying to take this to IAPB, the Climate Action Working Group. We closely work with them with all these activities, and of course with iSustain. And what we see, at least in Arvind, is this, they say 3 Ps, but I'm just adding one more P. If you have a clear purpose, and if you center the care around patients, you will make profits, and you will be friendly to the planet. And I again thank you for being a part of this important symposium. Even though we have a thin crowd, I think we have a very passionate team here. If you have any questions, Chang is here, Uday is here. Yes, Carl.
So I have a question. So I'm a neuro-ophthalmologist. I have not done cataract surgery since I finished training in 1990. I've never done a phaco. But has anyone looked at the carbon footprint of phaco versus M6? It seems like the data shows M6 is just as good as phaco in terms of outcomes. Correct me if I'm wrong. What's the carbon footprint of phaco versus M6, and should we be looking at that?
Very good. It's a good question. We have not looked into that. I mean, practically, I had looked, but we have not published yet. If you take, if that is 1/20th, the phaco waste at Aravind, then it is, you generate 1/5 by SICS. Because at the end of the day, your phaco cassette is the only one which is adding to the weight, whereas the rest of that is similar to both.
But you got the carbon footprint of making the phaco machines.
Oh yeah, we have not looked into that. No, we are not really looking into that. We are just looking at the cassette and the tubings which you use in that particular day for 25-30 of your phacos. But if you look at the electricity behind it, and of course the machine, the manufacturing, how much of water goes into all that, if you do an LCA on that, then there will be a terrific difference. Chang, you want to answer that?
Well, the great thing about sharing this is everyone has great ideas and things come to mind right away. And, another one that comes up is, and the Europeans did a study on immediate sequential bilateral cataract surgery, doing surgery at the same time, because the footprint of the travel for the patient is actually pretty high. Again, that depends on where you live and it's public transportation or not. And a huge savings, as you would imagine, both cost and emissions when you do bilateral surgery. But I think this is hard enough to get people to think about, to care about, that any time you bring in actually changing practice, that's a huge jump. So how you do phaco, doing 2 eyes at the same time, that's so controversial, and it's, there's the reimbursement issues and so forth. People have looked at the coming to meetings, the amount to take a plane flight to come to a meeting versus a virtual meeting. People have sort of said, do we want to do everything virtual? So you start taking it in these directions, and I think the approach that we need to do is, instead of changing behavior dramatically, which there's merit to talking about, like what we eat and so forth, I think that where we can all get on board is we're doing something really frequent, and we want it to be sustainable because we are curing blindness and preventing blindness. And if we can look at all these things that are unnecessarily being wasted, it doesn't change how we practice. That's probably where we're going to get momentum, and that's kind of, I think, where the focus, is going to be most effective. But I've certainly learned a lot, about just measuring things. One of the things is just measuring what the carbon footprint is. We would use 5 viscoelastics per case until someone tells you how much a viscoelastic costs, and then you kind of go, oh, well, let me try to just do 1. So once we know the cost, then we kind of can use our judgment as to, do I really need this or that? Well, quantifying the environmental cost is something that needs to be done, and that's what that CITICS calculator from ESCRS does. It actually tells you what you would save in terms of carbon emissions. And I like the way that Vinky and Cassie Teal did this. You know, this is the CO2 equivalent that you save per year. Well, just translate that into one FACO is driving an automobile 300 kilometers. Well, wow, that's a lot. That's a lot. And so quantifying what things cost, not just financial, but in terms of environmental, is another a good way. Yeah. Any other comments, since we have a small group? But appreciate the comment, Carl. Yeah. Yeah. Well, I would say that neuro-ophthalmologists probably contribute the least to the carbon footprint of ophthalmology. In general, yeah. Although those MRI scans could probably have a little bit of a footprint.
Hello. Though I don't have a question, I just came across this topic when I was going around the program. And what interested me was, I'm from Nepal, from a hospital called Biratnagar Eye Hospital. And we have been closely following Arvind Eye Care System for around 40 years. And recently we have given this carbon footprint work to one of our consultants who is actually measuring the carbon footprint produced from our side. So this session was really interesting to me, and maybe in future we'll be working more into this. Thank you.
Thank you for coming.
Pleasure having you. Yeah. Okay. Thank you.
Yeah, thanks everybody.